So we reported on our study with pembrolizumab maintenance as a treatment strategy for patients with relapsed refractory Hodgkin lymphoma. And so this is really moving away from, or evaluating a treatment strategy that's really moving away from the standard of care. The standard of care for patients who have relapsed refractory disease following frontline treatment, this is Hodgkin lymphoma, the standard of care is to receive some kind of second-line therapy followed by consolidation with an autologous stem cell transplant. Now that's been the standard of care for several decades based upon fairly historic data. But the reality is that we now have newer drugs for Hodgkin lymphoma. The landscape has changed significantly, and so now we're starting to ask whether everyone needs high-dose therapy and autologous stem cell transplant in the second line setting. And so this study is building upon our prior study where we evaluated pembrolizumab plus gemcitabine, vinorelbine, and liposomal doxorubicin. That was evaluated as a second-line treatment that we used as a bridge to autologous stem cell transplant, and we saw a very high complete response rate with that regimen. 95% of the patients had a complete response, and actually now with 5-year follow-up, we still have seen that only one patient relapsed within the whole group of 38 patients on that study. And so building upon that, we decided to look into whether we could use pembrolizumab maintenance after achieving a complete response to pembro-GVD rather than have patients go on to consolidation with an autologous stem cell transplant. And so this was really somewhat a pilot study. It was just 24 patients who had achieved a complete response and then went on to maintenance. They received up to 13 doses of pembrolizumab maintenance. Of those 24 patients, we did have 10 patients end up having their disease come back. Some of them had it relapse during pembrolizumab maintenance. Some were sometime beyond their maintenance. Of those 10 patients, we were actually ended up giving them additional salvage, and then 9 of those patients have now already gone through a transplant and have been followed for quite a long time already. And then the one patient who didn't go to transplant really was not eligible for transplant due to comorbidities, and so we gave that patient additional treatment with pembrolizumab and gemcitabine, and that patient actually went into remission. And so ultimately, it was actually gratifying that a portion of patients seemed to be cured with just the maintenance, but of the patients who were not cured, who had their disease come back, we were able to get them back into remission and get them to transplant. And now with fairly reasonable follow-up, it looks like those patients will likely be cured. We're learning that we could potentially use maintenance as a strategy to see if we can get away with transplant, but for patients who relapse, we can pretty successfully get them back into remission and get them to transplant and hopefully not sacrifice their chance of being cured in the long run.